Good afternoon, everyone. Thank you for joining us. If you are rejoining us after hearing Dr. Anderson's presentation, welcome back. We're glad you stayed with us. If you are just joining us right now, welcome to the 2021 MSU AgeAlive Forum. We're thrilled to have you here. My name is Claire Laws. I am a gerontologist in the College of Osteopathic Medicine. I'm also the director of AgeAlive, and I am your host for the next hour and a half. I'm going to introduce our panelists in just a few moments, but first, several helpful hints to hopefully make your experience during this event as good as it can possibly be. If I had time, I would tell you all about AgeAlive, but I don't. So instead, I ask you to visit our website at www.agealive.org or email us at agealive@msu.edu. This is our third annual forum. It would have been our fourth had we not had to cancel last year's because of COVID. And the theme this year is lifelong well-being. I'd like to take just a minute to thank those who have made this possible. Again, a heartfelt thanks to the AgeAlive Leadership Council, to the Forum Planning Committee, and I will just give a quick and heartfelt tribute to our dear friend, and the co-founder of AgeAlive, Barbara Sawyer-Koch, who started helping us to plan this forum over 2 years ago. She was an active member of the Planning Committee. So a shout out to Barb, wherever you are. And many thanks to the MSU Alumni Office that has given us invaluable support throughout the registration, planning process, and technology, especially to Amy Carnahan and Devontae Kennedy, who are behind the scenes right now, providing technical assistance so that all goes smoothly, as I'm sure it will. But if it doesn't, if we have some glitches, we ask for your grace and forgiveness, because this is the first time we've done this forum on this platform. So a few tips, a reminder that this is set up so that only the presenters can be seen on camera and heard. We will have a very limited question and answer period once all of the panelists have finished their presentations. However, you are invited to submit your questions at any time using the question and answer feature that Zoom offers, which is different than the chat feature I just recently learned. You should have an icon for both of those on your screen. We will do our best to get to as many of your questions as possible at the end. If you have other items, not questions, but other items you need to communicate to us, you can use the chat feature. And finally, please take a few minutes once the program is over to fill out the evaluation form that will pop up automatically. So now moving into the reason that you are here, the AgeAlive research panel has become an audience favorite over the last few years, and it is a way for us to showcase some of the great and diverse aging-related research happening at MSU. The panel reflects our commitment to recognizing the contributions of different generations, different disciplines to the richness of life, and the topics touch on an array of factors that affect well-being. Each panelist is going to have about 10 to 12 minutes to present their research. I'll be giving them a reminder at 10 minutes that it's time to wrap up, and then we will move on to the next panelist. And we're going to save questions, as I said, to the end. Now it's my pleasure to introduce you to our 2021 panelists in the order in which they will present. And I invite all 5 of them to join us on camera for just a couple of minutes while I introduce you. And all we need is Dr. Kotval-Karamchandani. But I'm going to start with introducing her. Dr. Zenit Kotval-Karamchandani is an assistant professor of urban and regional planning with the School of Planning, Design, and Construction. Her research interests lie in the environmental and health impacts of the built environment. She also has active research projects that examine the physical and mental well-being of older adults and how this is affected by increased mobility through specialized transportation services. Additionally, she researches food security and accessibility, both within the US, specifically in Michigan communities, and internationally as well, focusing on the city of Mumbai, India. So thank you for being here today with us. Dr. Fei Sun is a professor in the School of Social Work and coordinates the Lavandi Geriatric Social Work Certificate Program. And I'm pleased to say that Dr. Lavandi is serving on our Leadership Council. Dr. Sun received his doctoral degree from the University of Alabama in 2008. He is a fellow of the Gerontological Society of America and was a Hartford Geriatric Social Work Scholar. Awarded as a Health and Aging Policy Fellow, he's been working with the World Health Organization in their Department of Mental Health and Substance Abuse on developing a global toolkit for dementia-friendly communities. His overall research area is aging and mental health with a focus on addressing the impact of Alzheimer's disease and related disorders in the Chinese American community. And Dr. Sun has received multiple research grants and has published over 80 peer-reviewed articles. His practice interest focuses on psychosocial interventions for individuals with dementia and their family caregivers from ethnic minority backgrounds. Thank you, Dr. Sun, for being with us today. Dr. Scott Counts is an associate professor in the Department of Translational Neuroscience in the College of Human Medicine. He received his undergraduate degree from Davidson College, concentrating in English and history. He worked several years as a chemist at the U.S. Centers for Disease Control, went on to earn his PhD in neuroscience from Emory University, studying mechanisms of familial Alzheimer's disease, and then joined a research team at Rush University Medical Center for postdoctoral training, followed by a faculty position. He joined MSU in 2013 at the Grand Rapids campus. His current research, which you'll hear a little bit about, focuses on identifying mechanisms of neuronal projection system vulnerability in mild cognitive impairment, Alzheimer's disease, and related disorders, as well as vascular contributions to dementia. And he and his team their hope is that their research will lead to disease-modifying therapeutics. And then next, we will hear from Dr. Suzanne Cross, who is an associate professor emerita in the School of Social Work. She's a citizen of the Saginaw Chippewa Indian Tribe of Michigan. Dr. Cross has taught social work practice, policy, gerontology, American Indians, elective courses for over 20 years at 3 universities. Her research includes American Indian grand families, Indian child welfare, and historical trauma and behavioral experiences impact on physical pain. She's presented her work at professional, regional, statewide, national, and international educational and tribal conferences. She served on the Council of Social Work Education Board of Directors, received their Senior Scholar Award to research the status of American Indian elders. She's dedicated to the collaboration between academia and tribal nations for the benefit of both. She is a traditional dancer, a beadwork artisan, and she and James, her husband, have provided foster care, both formal and informal, for American Indian children. Thank you, Dr. Cross, for being here. And finally, last but not least, is Nicholas Hallenbeck, who is a second-year medical student in the College of Osteopathic Medicine. He went to Central Michigan University for his undergraduate degree in kinesiology and biomedical sciences. He and Jose Reyes, who could not be with us today, he is our AgeAlive MSW intern, have been invaluable to the research that Nick is going to present today, and they both serve on the AgeAlive Leadership Council. So currently, Nick is undecided on his future field of medicine, but wherever he lands, he says he will be involved in community health. So thank you, Nick, for being with us today. So let's get started. I'm going to ask, I will be disappearing in just a moment, as will the rest of the panelists, but we're, Dr. Kotval, if you could stay with us and kick us off. Thank you for kicking us off this afternoon. And the rest of us are going to disappear and give you the floor. Thank you.
I hope that my screen is visible. Thank you, all of you, for joining us today. I will say it is very hard to go after Dr. Anderson. I would hope that that hour didn't end and I could keep listening to Dr. Anderson's stories, but it's my turn, and I am happy and excited to present the research that I've been doing with my wonderful colleague, Linda Keilman, who's also a gerontologist in the College of Nursing. And I'm going to present the relationship between transportation and preventive healthcare for older adults. My name is Zinat Kotval-K. I am a faculty member with Urban and Regional Planning in the School of Planning, Design, and Construction, and I'm in the College of Social Science, which is a little bit different when we think about health and health data. So just to set the stage, the background, we know the older adults are the fastest growing cohort. By 2030, all baby boomers are going to be over 65 years old. 1 in 5 are going to be retirement age. Currently, 41% of all older adults in Michigan live alone. Over 30% of them have a disability. And that is why I feel this need to research impacts of transportation on the well-being of older adults. I got into this through my mom when she moved from India to East Lansing. And so I got into that 5 years ago, never left this field. I'm going to keep trying to get transportation better for older adults. Aging in place, quality of life, these are all very important aspects. And transportation services are critical for these. They would help, better transportation services, I feel, would help alleviate the physical, mental, and social isolation that older adults feel, especially when they're advised to stop driving. And so this connection between transportation and preventive healthcare attainment is a new field. In the literature that has been done, specifically in social sciences, we know that transit systems pose barriers for the elderly, right? There's talk about stops that are not ADA compliant, seasons play a role. So, older folks cannot walk and wait at a bus stop when it's cold and snowing outside. The distance from the residence to any special needs that they need to get to, transportation services and healthcare attainment. There is research that has been looking at urban versus rural areas, accessibility to healthcare facilities, and missed appointments. And we're still trying to get at the reasons for these missed appointments. No research would be done if you don't look at socioeconomic characteristics and healthcare attainment. So income and racial factors compound the barriers to healthcare. And so does having insurance. So all of these have been proved in the literature, but what we're trying to do in the study is look at the prevalence of transportation services, specialized transportation services for older adults, and their attainment of preventive healthcare services. We have this data from the 500 Cities Network. It's a brand new, well, now it's not brand new, it's 2 years old, initiative by the CDC and the Robert Wood Johnson Foundation. It gives you health information and outcomes at the census tract level for the 500 largest cities in the US. We also took socioeconomic characteristics from the census and then transportation provision services, specifically for older adults, from agency websites for the cities that we had this 500 cities data for. So this map shows you a broad range. There are 16 cities that were included in that 500 cities database, 16 of the largest cities in Michigan. And you can see that they're all obviously in the Lower Peninsula. If you zoom in a little bit, this slide shows you where the cities are, and the color scheme tells you healthcare attainment, preventive healthcare attainment for older adults in these cities. And you can see that it ranges from just 22% to a little over a third in Livonia for 36%. I feel that these are extremely low rates for older adults that have had preventive care taken care of. And when we talk about preventive health care, for men, it's, have you had a flu shot, a PPV shot ever, colorectal cancer screening? And then for women, it's all of the above, plus a mammogram in the past 2 years. So it's not an extensive list. It's simple measures that go into this preventive health care. And what we did first was, I won't be showing you, for lack of time, I won't be showing you the maps for all 16 cities, although I do have them, but just a few of them. And what I'd like you to notice first is that the shades in green on your maps are the healthcare attainment percentages. All right, so you want to see where the lower or the lighter shades of green are and what those correspond with. The yellow dots or bubbles, or the orange dots or bubbles, are poverty rates, specifically for older adults. And then the bars show you percentage of non-whites, specifically in the red bar, and the blue bar shows you households with no vehicles present, which is why transportation is such an important piece. So I'm hoping that you try and discern these areas that have lighter green colors, larger bubbles showing that less preventive healthcare attainment coincides with higher poverty rates, and many times it coincides with non-whites in those census tracts. So this is Ann Arbor. I have a Grand Rapids map to show you, and you should see that the lightest and the next shade of green have the highest rates of poverty. Also, the lightest green has the highest rates of non-white population. This is Dearborn. If anybody's familiar with Dearborn, the upper northeast corner is where the Arab immigrant population lives. So there is a higher percentage of non-whites plus higher poverty levels up here. Lansing. Again, you should be able to notice the percentage of non-white population, higher poverty rates, and lower levels of preventive healthcare attainment. So once you start going through these maps, you do start getting to see this trend. I would be remiss if I didn't show Detroit. So I know the first thing that, you should be able to see is a lot of red bars. Well, yes, Detroit is mainly non-white. To me, if you ask me, the first thing I see is the shape of a heart, but that's just me. Okay, I'd like to clean this up a little bit just to show you the base. A lot of poverty rates coincide with lower levels of preventive healthcare attainment. So this is the visual representation. We did, for those interested in statistics, we did do regression analysis. We ran 2 models. The first model, basically, we put only transportation variables in it, and all of the transportation variables turned out to be statistically significant with rates of preventive healthcare attainment. But once you start putting in socioeconomic characteristics, so model 2 has transportation and socioeconomic characteristics, and we see some of the transportation characteristics become non-significant. So we have to understand that there are significant relationships for sure between transportation and preventive healthcare. Socioeconomic variables also have a very big impact on healthcare attainment. But still, there are these minute nuances that are involved in aspects of transportation and healthcare attainment, missed appointments. And the researcher in us just wasn't happy with, okay, this is what we said we would do for the grant. We've done it, just not happy. So we wanted to know more. There is something behind it that we're not seeing in just numbers. So through the help of wonderful people at the Tri-County Office on Aging, we spoke with a couple of representatives from the offices on aging. One from Tri-County, their jurisdiction is the three counties, Ingham, Clinton, and Eaton. And we spoke with someone from the Detroit Area Agency on Aging. And the results that came out, the reasons that they were able to share with us that their constituents would not be able to attain preventive healthcare attainment, dealt with a few different things. For Tri-County Office on Aging, so for the Lansing area, scheduling constraints, and most likely they are unaware of the transit services that are available. And we're talking about specialized transportation services. So not your regular CATA bus, but more like SpecTran, where it's demand response. You call, you book a ride, and they come and pick you up. So they're aware of the transit services, unaware of them that are available, and unaware of what is actually covered in their insurance. The fact that you have to have an advanced reservation to be available, for you to be available to avail of the service, that is also a hindrance. But when you get to the Detroit area, it's the sheer size of the older adult population. Transportation is the single largest factor affecting preventive healthcare attainment. You do need the consistent, reliable service. They talk about transportation services that do not cross jurisdictions, and that is a problem even in the Tri-County area, actually. There is lack of funding for creative solutions. So, transportation coordinators and brokers, they attempt to provide relief, but it just adds to inconsistencies. The Michigan, the My Choice Waiver program has certain illness and income criteria that need to be met. With over 50% of older adults not having transportation covered in their insurance programs, cost is the single most significant factor that affects this. One of the representatives we spoke to said that the system is set up with the expectation that the family takes on the burden of transportation for older adults. So with someone who is living alone, and I mentioned that in the beginning, with 41% of older adults that live alone, this is hard. So in conclusion, I was just wanted to say that this data set allowed social scientists for the first time to compare socioeconomic characteristics with health data. Older adults are increasingly going to need to have considerable attention to be able to successfully age in place. Provision of door-to-door services is significant. Preventive healthcare attainment leads to more managed health and attention to healthy lifestyles. And transportation not only impacts preventive healthcare, but it also affects the quality of life for older adults. And with that, I'd like to end and thank you.
Wonderful. I got so caught up in your presentation, I forgot to give you a warning, a time warning. That was very interesting. Thank you so much, Dr. Karamchandani. So next in our presentations is Dr. Sun, Dr. Faye Sun, who I will welcome to the camera. And I am going to disappear. So for the next 10 minutes, we'll be able to appreciate Dr. Sun's research.
Great. Well, thank you, Claire, for your introduction. It's great. I'd like to thank AgeAlive for this great opportunity to not only just to present my work, but also it's a great opportunity to know my colleagues' work. It's good to know, Janet also does something in aging place. What I'm going to talk about is dementia-friendly community. And particularly, I want to highlight the challenges that are faced by those dementia-friendly communities before and during the COVID-19 pandemic. I'm Fei Sun. I'm a professor with the School of Social Work at MSU. This project is funded by our college, which is College of Social Science. I also like to acknowledge my research team. I know some of them may probably in the audience. I have to thank you for your contribution to this project. So dementia, due to Alzheimer's disease or other types, has become a global public health concern. Currently in the United States, about 6 million people are living with dementia. In the state of Michigan, the estimate number is around 200,000, which is around the size of the city of Grand Rapids. And the rate, of dementia is increasing. Every new year we have like every year there will be like 10 million new cases. So dementia not only affects people's memory, ability to solve problems, decision-making, and eventually daily living, but also cause enormous burdens, financial, emotional, and physical burdens of family caregivers. So in responding to the impact of dementia, WHO, World Health Organization in 2017, they highlighted 7 action areas that they suggest for governments around the world, particularly to the member states, to adopt a holistic approach to address the impact of dementia. So not only seeking biomedical treatment, but also providing psychosocial support and policy advocacy for persons living with dementia. So I often encounter clients who recently got a diagnosis with Alzheimer's disease come to talk to me, say, once I got diagnosis with dementia, my world becomes smaller. My friends stopped calling me. I did not feel welcomed at my church. The whole world seemed to shutting down to them. So that's also the same for family caregivers who also feel socially isolated because of the burden of taking care of loved ones with dementia. So among the 7 action areas, what I'm going to focus on today is dementia awareness and dementia friendliness by creating a dementia-friendly community. By offering an environment that is inclusive, respectful, and honoring the personhood of person living with dementia. Dementia is often rated one of the most fearful disease, and also one of the most misunderstood disease by Americans. So one of the stigma associated with dementia is once the person has dementia, they are deprived of their personhood. They lost of their self-identity completely. But I would say that was the myth. If someday I have dementia, Faye had dementia, I'm still the person who loves sweets. I'm still the person who do not like Panda Express. I'm still the person who like to share my bad jokes. So the self-identity piece is still there. So dementia-friendly initiatives are those community events, community movements launched, typically championed by local NGOs and statewide NGOs to provide an inclusive and friendly environment that will involve and engage persons living with dementia. The 3 essential features of DFI, as I highlight here, is the centering on the needs of persons living with dementia. By hearing their stories, hearing their narratives, having their voice heard, also respect their uniqueness. By encouraging multi-sector collaboration, particularly the social care and healthcare sectors. By also, like just Dr. Zinat has mentioned, the built environment and the social environment modifications, like the physical environment, by including the transportation system. How can we make our transportation system not just age-friendly, but also dementia-friendly? By providing, sufficient signage, appropriate levels of stimulus. So those are all efforts that dementia-friendly initiatives are trying to launch to provide an inclusive environment. Worldwide, there are about 46 countries in this world who already have some levels of dementia-friendly initiatives. Let's take a look at the USA. So in the United States, in 2011, under the Obama administration, we passed the National Alzheimer's Project Law. one of the goal of the NAPA is to raise dementia awareness and create dementia support. So the national DFI network is championed by the National Associations of Area Agencies on Aging, which we call the Aging Network. You know, some of you may have interactions with the AAAs. And by looking at the map on this slide, which is derived from the Dementia for America, you can say almost 40 states in the United States have some levels of dementia-friendly initiatives. In the state of Michigan, you know, according to that list, there are 2 cities, Grand Rapids and Saline, which is a town to the south of Detroit, to the south of Ann Arbor also, are listed as dementia-friendly cities. However, based on my knowledge, there are many other communities in Michigan. They are either launching or developing dementia-friendly communities, but without being listed on this map. For example, like Battle Creek, Kalamazoo, Battle Creek, the Region 1B, 3B areas. So during the COVID-19 pandemic, I think most all of us experienced a little bit of sense of social isolation. And the social isolation could be more severe for persons living dementia. For those at early stages, you know, the overabundance of information about, you know, sanitary precautions may be hard for them to follow. You know, for example, they have difficult following social distancing when they do grocery shopping. For those at moderate or later stages, you know, they may lack of access to adequate care or service that it could normally have because of the social restrictions. And there are also researchers have found, you know, dementia actually put the risks for having COVID-19 twice more than those without dementia. That's a study in the US. And other studies in other countries have found that the dementia burden is related to this country's COVID-19 cases. And the dementia has been a comorbidity factor for those who are affected by COVID-19. So all this saying, you know, people with dementia are at high risk for COVID-19. And this is a concern or phenomenon we need to pay attention to. So this research is similar to Zina's research. We also use the mixed methods approach. But what I'm going to present today is just the qualitative part. And for this qualitative part, our major research question is to find out what are the challenges and the strategies, you know, from the perspectives of stakeholders involved in dementia-friendly community building. So how has the pandemic, specifically, how has the pandemic affected, you know, dementia-friendly initiatives in fulfilling the needs of persons with dementia? You know, what strategies have they used to address those challenges? As I said, this is a mixed methods approach, so it involves the qualitative parts, which is individual interviews. We interviewed 9 stakeholders in 7 states who are running dementia-friendly initiatives. We also did an online survey, which is open to all the participants involved in DFI worldwide. So we got 268 participants in that survey, which we are in the process of analyzing data, which will not be presented today. What I'm going to present today is the findings from our qualitative interviews. So the 9 interviewees who participated in our study, who are most from the NGOs, there are 5 of them from the NGOs, community-based organizations. 1 is from a government agency, and 2 of them are from a faith-based agency. Most of them, they are actually frontline workers. They are the program coordinator or the program administrators that are in charge of implementing the dementia-friendly communities. And we also have a champion who is a person actually living with dementia, who serves as a consultant for dementia-friendly community. The 7 states that we draw samples are Colorado, Illinois, Michigan, Texas, Wyoming, and Massachusetts, and the Washington, D.C. area. So now I'm going to highlight some of the major findings from those interviews. So the challenges prior to COVID-19 One of the major challenges is the low engagement and involvement of persons with dementia. That has been manifested on 2 levels. One level is, for all those activities like memory walk, dementia awareness events. They try to engage people with dementia to share their narrative, to share their stories. There is few participants from the person living with dementia community are willing to do that. And the second level is, even when they're planning or launching those dementia-friendly community designs, there is lack of involvement of person with dementia involved in the design and the planning phase. So the second part could be the reason, could be partial of the reason why there's a low engagement of person with dementia. Other reasons could be, there could be strong, stigma attached to or strong barriers for persons with dementia to engage in those activities. For example, like a family opposition, out of the concerns of the safety of the person with dementia, some families may become overprotective. They are not, allowing person with dementia to join those activities. But on the other hand, that demonstrates that the stigma toward person with dementia. You're assuming the person, once they have dementia, they lose all the capacity for social engagement. The second challenge prior to COVID is the organizational barriers. As I mentioned, the dementia-friendly initiative involves multiple sectors across agencies, try to break down the silos in government agencies and other community partners. However, we still, those stakeholders still reported that existing barriers for agencies to participate in dementia-friendly communities. For example, local business, some businesses are very willing to, say, have a dementia-friendly cafe, or have special accommodations for people with dementia, while other businesses, they are not welcoming those ideas. Last is the sustainability challenges. That's similar to any other community initiatives, like the lack of funding, loss of momentum at the later stage. Those are the common sustainable challenges. The challenges during COVID-19, I just want to highlight one of it, which is the difficulties of transferring some of the in-person activities or interventions to technology-based format. Part of the reason is some families or some person living with dementia, they have low technology literacy or even have poor access to internet that prevents them from using those services. And the other challenge is because some of the activities, they have better outcomes when they are delivered in person. It's really difficult to transfer them through a Zoom-based activity. I'd like to share one quote from a stakeholder from the Michigan. That person is a CEO from a dementia-friendly community initiative in Battle Creek. So she reported, the challenges to get all the community partners sitting together and to understand what it is and what is our next step and how they can work in together. Similarly, a person from Illinois, resonated with, some other challenges. Like, they are considering doing an information session by Zoom. However, the biggest challenge is, it's difficult for those people who be reached out by technology. So strategies, prior to COVID-19, we do find some resilience in those community organizations who are implementing DFIs, using local person with dementia or caregiver champions to engage person living with dementia and to influence the general public is one of the strategies. Later on, you are going to see a picture from Emma, Michigan. So Mark and his wife, Brenda Roberts, some of you may know, they are local champions and Mark is a person living with dementia. Brenda is a caregiver. So they are local champions who give talks about dementia all the time, and they are actively involved in building a dementia-friendly community in their neighborhood. Partnership is another strategy. by seeking resources and leveraging all those resources can be collected from different partners to sustain DF activities. Strategy during COVID-19 pandemic, I just want to highlight one of it, which is also related to technology, is modifying the format of delivery from in-person format to use technology-based provision. When I mention technology, it's not just limited to like advanced technology like Zoom access. I noticed there are two audience in this AgeAlive forum who are participating with us over telephone. You know, the rest of most of you guys are listening to this via internet access, but there are two. But I suspect there are probably many more of them couldn't participate in this AgeAlive event because they do not have internet access. So what the DFI coordinators are doing is they're trying to reach out to people using different technology means. That includes like using landline telephones. For the sake of time, I'm not going to read the quote. Lastly, I want to just highlight some applications for our practice. So COVID-19 did exacerbate some existing challenges for communities that are launching dementia-friendly initiatives. And we also observe disparities and variations in dementia awareness and resources in different regions. For example, the state of Massachusetts, they are launching a statewide dementia-friendly state, which means they have more resource and policy support in that regard. Innovative practice is observed during the whole process by emphasizing person-centered and technology-based approach. When I say person-centered, that is combating the stigma or stigmatized image toward a person with dementia, consider them totally lost their self-identity. By doing person-centered approach, by giving back their personhood, by honoring their uniqueness, their social relationship. You know, for example, like the one picture you see in the middle of the slide is Mark. Like the dog, the pet he's holding is called, his name is Sophie. Sophie has a GPS chip inside it, so it goes anywhere, you know, where Mark goes. So for example, if you are socially isolated, do not have social friends, having a pet, you know, which means pet is meaningful to you. So using capturing people's personal preference and honoring it. So that's one approach. Technology-based, you know, in addition to like internet access, we can circle back to old technologies where those people living with dementia are to support them and reach out to them. So lastly, I want to say we need all of you to create a dementia-friendly community because of two reasons. One is your participation, your friendliness to person living with dementia help create an inclusive environment for those who are already living with dementia. Second, research studies have shown that, particularly based on two studies from the School of Public Health and School of Medicine and Yale University, if person hold positive attitudes toward aging or toward dementia, that actually reduce the risks for you to develop in dementia. They actually did studies for those who carry the risk genes, ApoE4 genes. I believe Scott maybe mentioned this as well, to carry out the risk genes for Alzheimer's disease and found those who hold positive attitude toward aging or toward dementia are less likely to develop in dementia. And thank you all for your time, and I will accommodate to any questions in the chat box later.
Thank you, Dr. Sun. Your research is so important, and I will let you know that Dr. Sun is encouraging Michigan State University to become a dementia-friendly university. So next up, we have Dr. Counts. Welcome, Dr. Counts. I'm going to disappear and let you take the stage.
Oh, hopefully you guys can see this. Let me maximize. So excuse me, I need to get rid of, oh, so yes. So thank you, Claire, and thanks, Dr. Anderson, for a great talk earlier, if you're still on the call. And again, thanks to the whole organization and the fellow panelists. It's, I'm already learning stuff and look forward to learning some more. So, caveat, I study the molecular and cellular aspects of dementia. And so to attempt to describe one of our research projects in 10 minutes, it would just be absolute complete gibberish. And so, but what we can talk about is something extremely important to the dementia field, and that is modifiable risk factors for dementia. And this is something that we are definitely interested in. Claire mentioned that we are interested in vascular contributions to dementia, and this certainly represents a modifiable risk factor, and we'll talk a little bit about that. I did want to mention that if you have questions later, if they come up, there's my email address at the bottom. Feel free to reach out. So first of all, in talking about, let me also get my, so let's start with, first of all, we need to talk about how dementia is actually an umbrella term. We usually think of Alzheimer's disease, and that's because it's the most prevalent. But there's also vascular dementia that arises from, say, strokes. And then we have less common dementias, such as Lewy body dementia and frontotemporal dementia, that are also very severe diseases. And for any of you out there who have been caregivers or care partners for any of these, for folks with these disorders, bless you. So first, let's talk about things we can't control. Age, of course, right? The older we get, the greater our risk becomes. Unfortunately, for reasons we don't quite understand yet, the females are more likely to have dementia than males. And then also for reasons we don't quite understand yet, are that there are ethnicity differences. So for instance, Blacks are 2 times more likely and Latinos are 1.5 times more likely to develop dementia than, say, whites. And so I say things we can't control. These are things we need to control, okay? We just can't right now. And so first of all, to get rid of this health disparity, because it's a profound health disparity, but also by understanding what's causing these disparities, that's going to help us understand the disease better and get us to a treatment. And then, of course, another thing we obviously can't control is our family history and genetics, and some of these genes that have very slight alterations in them that are passed down to us and increase our risk for dementia by a little bit at least. Let's now talk about things that we can control or that we can control, and these are the modifiable risk factors that we're discussing. So a few years ago, the Lancet Journal, a British medical journal, commissioned an international panel to look for these modifiable risk factors. And they scoured the literature and they came up with 9 modifiable risk factors that collectively would reduce dementia risk by 30 to 35%. Okay, and it actually occurs over the lifespan. So early in life, education, quitting school before you're 15 years of age tended to confer a risk factor, so less education up here, okay? And on the flip side of this, we know that lifelong learning can lead to cognitive resilience. So your brain, through educating yourself throughout your life, you build up a sort of a plasticity that we call it in the brain, where you're able to sort of withstand pathology that's sort of emerging better than someone who isn't exercising their brain and is a little more vulnerable to the pathology. So in midlife, that's where things really start taking off for us, unfortunately for folks like me. And that's, we have hypertension and obesity, hearing loss, which is interesting. It's thought that hearing loss can lead to the sort of social isolation and a lack of cognitive and stimulating interactions. And so interestingly enough, only 30% of people who need a hearing aid actually wear one. And so that's, of course, something that we can work on. And then in later life, we have several risk factors, including diabetes, physical inactivity, smoking, depression, and again, the low social contact. And again, this is a big concern during the COVID era, as Faye was mentioning. And then an update just last year added 3 more risk factors: traumatic brain injury, alcohol abuse, and this is in middle age, and then again, interestingly enough, air pollution in older age. And so collectively, all of these risk factors, these 12, if we could control for them, that would reduce our risk for dementia by 40%, which is pretty incredible if you think about it. And so let's focus then, since it's we obviously can't talk about all of these risk factors today, but we can, since it's springtime and we're kind of getting out of the comfort food season, and it's actually, you can actually go outside without risking hypothermia. Let's talk about diet and exercise and how that can combat or modify one of the major risk factors for dementia, and that's collectively referred to as metabolic syndrome. And this refers to hypertension, high blood sugar, which can lead to diabetes, high blood cholesterol, and what we call triglycerides, the saturated or trans fats. If you look on a package and it says hydrogenated oils, that's them trying to trick you. That's what that means, and that can lead to what's called hyperlipidemia, and that can lead to hardening of the arteries. And then all of these things together can lead to altered blood flow in the brain. Okay, and so of course a lot of this is genetics, right? So you have your good and bad cholesterol that you can inherit, and things like that. But a lot of it's self-inflicted, right? So there's that smorgasbord. It's probably awesome. It'd probably take me 3 days to eat it, but it's not going to be good for our brains, right? And we know from countless epidemiology studies and animal studies, you name it, that metabolic syndrome, the hypertension, the diabetes, et cetera, doubles our risk for cognitive impairment. And that can be reduced by diet and exercise. Okay, and so to put this into theory for us, is we have the MIND diet. And this is the latest diet that's in the research field that's being tested. And so the MIND diet combines the Mediterranean diet with the American Heart Association DASH diet. So it's more of a low sodium diet. And so, we've heard about these types of diets. It's fruits and vegetables and, fish and poultry and whole grains and minimizing, the sugar and the flour and the saturated fats which promote oxidative stress and inflammation. Okay, and so, that's the theory, right? So what about the practice? Well, here are 2 studies that I hope can sway you. So the first one was the Health and Retirement Study, which is a British study, and these are 6,000 healthy older adults. And so they found that those who closely adhered to the MIND or Mediterranean diet had a 35% lower risk of cognitive impairment, whereas moderate adherents lowered their risk by 20%, right? And then in another study, this is the Women's Health Initiative, which is in the US. And again, this is, remember, women have a higher risk for dementia. So, and this is actually referable specifically to Alzheimer's disease. But they found that close adherence to the MIND diet had a 35% reduction in risk for Alzheimer's, but even moderate adherence had a 20 to 25% reduction in risk. So again, the take-home lesson is, you don't have to be perfect with this. You just need to, do your best. It's okay to go by the Taco Bell every now and then, right? But for the most part, we want to try and stick to these healthier diets because they do seem to have a risk in these very large population studies. The second one I want to talk about is exercise. And, I could talk for an hour about all the different studies that have shown the positive benefits of exercise. And I know we know this just from the popular literature, but one study I wanted to point out was this 1-year walking program for mild AD patients. Okay, and so these were people with early stage Alzheimer's disease, and they were divided into 3 groups. One group walked for 2 hours a week for a year. The second group walked for 1 hour a week for a year. And then the third group was just sedentary, no exercise. 1 year later, what they found was that the sedentary group actually showed a continued decrease in their cognitive abilities. Okay. The 1 hour group, the 1 hour walking group actually stabilized over the year, but the 2 hour group actually showed some cognitive improvement. And this is actually pretty remarkable. But again, we go back to this whole business of you don't have to be perfect, right? Just the 1 hour group was able to stabilize and not deteriorate over that course of a year. And so what does exercise do for us? Many things. So obviously it improves our vascular health, and that's what we've been talking about. It lowers our blood pressure, lowers our blood sugar. It promotes better diet habits. So you get that diet and exercise, positive feedback loop, right? It can promote social contact, go out walking together, especially you get outside and when everyone's vaccinated and everything. And all this together, of course, improves your mental outlook, and you're just more, have a more propensity to connect with things in your environment and keep your brain active. And it also keeps your body more active as well. And so it combats fragility, so you can stay active longer and to continue to promote this risk reduction, right? And the interesting thing is that when you exercise, your brain actually releases protective substances. One is in particular is called brain-derived neurotrophic factor, or BDNF. And that actually protects the neurons or nerve cells in your brain when you exercise. And so to sort of put this, all this, to the test, if you will, they've been designing clinical trials over this. And the one that's really made the biggest impact so far is the so-called FINGER trial. So this is the Finnish geriatric intervention study. And what they did is they took over 1,200 people, elderly adults, and this was a 7-year study, but during that 7 years, people were enrolled and they had a 2-year intervention. It included nutritional guidance, physical exercise, computer-based cognitive training, as well as monitoring and controlling for vascular risk factors like blood pressure. And then they had a control group that had none of these interventions. And what they found was that the intervention group scored better in memory and processing speed, which you can kind of think of as, your ability to think on your feet, as well as executive functions, which you can think about as, like decision making and problem solving and making plans and things like that. Okay. And so this led to the Alzheimer's Association launching the Worldwide Fingers Network. And the reason for this is because no approved medications to date have produced the results as strong as this study, right? So there's, again, a pressing need to really continue to test this and to understand if really, in the absence of a treatment that's going to modify the disease, and you've heard about all this in the news with some of these drugs that just continue to fail. Maybe this multi-component lifestyle can reduce our risk for dementia, keep us, or at least extend our lifespan without dementia, right? Better than any drug could right now. And so these prevention trials are underway in over 25 countries. And the 4 main components, again, are the exercise, the cognitive and social stimulation, the diet, and then again, controlling for the vascular factors. So the take-home lesson then is lowering risk through lifestyle, right? So, exercise, eat right, again, I'll take care of those vascular issues. And one of the ways you can do that is by exercising and eating right, correct? And then again, some of the things we didn't talk about that I didn't provide specific data on were the beneficial effects, of course, of keeping your brain active and then keeping yourself socialized. And I would also mention that there's been a lot in the news about sleep. And if anyone wants to talk about that later, we can do that as well. But I will say thank you at that point. Thank you.
Thank you, Dr. Counts.
And I apologize for whatever was going on there. But anyway.
It happens. So that was really terrific, great concrete advice for everybody to follow. And one of the things we're learning is we definitely next year will provide a little more time for each of these researchers to show their research, because it's all so important and fascinating. And I don't want to shortchange anybody, so I'm giving Amy and Devante the heads up that, and all of you, that if you can stay on for just a few extra minutes tonight, we'll, I think, be able to hear both the 2 remaining speakers. So at this point, I'm going to turn it over to Dr. Cross.
Hello. Thank you for the invitation to present today. My topic is American Indian Women's Heart Health Awareness. It's my project, and share education with different tribal nations. and it's entitled Healing Through Culture and Art. And because the symptoms of women are often very different than men, 50% of the time. And I have case studies, but we won't have time for that. But I also am a woman who had the experience of cardiovascular disease. So I'm going to start real quickly here with a video that was put together by Indigi Dreams and myself. And we'll get it started and talk after.
In January 2003, I returned home from teaching with my arms full of books and papers. I could not catch my breath. I thought at first it was because the textbooks were too heavy, or perhaps I had a respiratory infection, or maybe I was just too cold. I found taking shorter breaths relieved the stressful feeling I had most of the evening. In the morning, I felt I could breathe normally. A week later, I talked with my primary physician about what I had experienced. He referred me to a cardiologist just in case there may be something wrong with my heart. The cardiologist asked me, "Do you smoke, drink alcohol, have high blood pressure, have pain down your arm, up to your jaw? Do you have a crushing pain in your chest?" I said no to all of his questions. He asked, "Do you exercise?" I said yes. "Do you have a family history of heart disease?" Yes, both my parents died of heart disease. He conducted a brief examination and then told me, "I'm 94% sure it's not your heart." Afterward, he gave me a prescription and sent me home. A month later, when I went back, he asked, "Did the prescription help?" I said, "Not with the shortness of breath." He appeared surprised and scheduled more testing, which showed 3 arteries were blocked, more than 90%, and others were 40 to 60%. I was prescribed medication and told I may need surgery in 5 years. But 1 year later, I had bypass surgery. 3 months later, I had a cardiac incident at the hockey arena. I felt ill. My hearing was muffled and the sound seemed to bounce off the walls. At first, I was concerned. But then I thought it was because the arena was so empty, which produced an echo effect. Next, my vision became impaired and the ice arena changed shape. I fell forward from the waist up. My husband helped me by pulling on my sweatshirt. I looked at him with unfocused vision and said, "I don't feel good. I'm going to try to get to the first aid room." Fortunately, it was only 20 feet away. I walked as fast as I could, hearing my husband telling the EMTs, "She doesn't feel good." One replied, "That's okay. We have a chair right here." I saw a wheelchair covered with a white sheet. I sat down and immediately slumped over. I could not see or speak, but I could still hear. One of the EMTs kept repeating, "What's your name? What's your name? Tell me your name." I could not respond. I thought, why doesn't my husband tell him my name so he'll stop yelling at me? I started to feel the other EMT touch my wrist and then my neck. I heard him call out, "I can't get a pulse. She doesn't have a pulse. I can't get a pulse." I knew I was in terrible trouble. I thought to myself, "Don't give up. I'm still here. Don't give up. I'm still here." I heard the EMT report, "Her blood pressure is 58/33. That was the last sound I remember. I was transported to the hospital for a collapsed artery. From my experience, I wanted to share a few points. Women's heart attack symptoms may be different. If you feel something is wrong, then get it checked. Don't be afraid or embarrassed to call 911. My cardiologist told me minutes are muscle. For every minute lost, there may be loss of muscle tissue. Finally, make sure you have a physician who is willing to take the time to answer all of your questions. During the winter of 2013, I began to wonder, what can I do to heal myself and overcome pain from a recent surgery? I remember I started a child's shawl, which evolved into 13 women's shawls that formed the Healing Through Culture and Art Shawl Collection to increase awareness and emphasize cardiac health care for American Indian women. They were exhibited at Ziboing Culture Center for 3 months, and they were danced in at the traditional Saginaw Chippewa powwow in June of 2015. Today, I often reflect on why the Creator let me live. Now, every time something positive happens, I think, this is why I'm here. Now I gotta get to
Okay, I just wanted to share that these women are from Navajo Nation, and they're the focus of the Indigi Dream organization, and they were in assistance in helping develop this video. And they travel around the United States and Australia and Greenland to continue telling individual stories one at a time. So I wanted to share their photo with you and let you know who they were. Healing through culture, art, and education. Cultural knowledge provides skills, abilities, and means in relation to creating the art. Art is a way of redirecting focus from and energy that may go to pain and focus it more in a creative way, which allows the individual to have choices, what medium they'd work in, size of the items that they will create, colors, time commitment, and offers a sense of choice as to bringing something together in a positive way. With an illness sometimes and or surgery, there's a feeling of being out of control. Individuals kind of take over your body and things happen and there's not a lot of control from your point of view. So I think art really helps bring that feeling back that you have some control and are able to make decisions and in a positive way. And then the art can be used as a way to create an awareness and encourage prevention, and that's what I do. I travel around to tribal nations and share about my experience and some of the other case studies that I have conducted, and also awareness of how women's heart health is different than men's 50% of the time. The shawl collection goals are to serve as a catalyst to bring cardiovascular disease awareness to American Indian women. And since I've been doing these presentations for a while, it's been more than American Indian women. And I've conducted sessions for Michigan Nursing Association and Federation of Women. And then the second goal is to share the value of culture as an approach to healing and wellness. For healing is not an event, but it is a process. Culturally relevant, can't read it, culturally relevant awareness models. During the literature review, I was able to find limited number of studies that indicated how best to share information with tribal nations and tribal people. And culturally tailored websites was one of the ways that can convey the information. I was a bit surprised that pharmacists were another but pharmacists, especially those who are working on reservations and also Indian Health Services, share information with their clients, and if they need to refer back to the ordering physician. Family members and community members share their experience, and they certainly do share. If you say just one thing that sounds a little negative, they want you to explain why that is. And so I'm really careful when I talk about medical professionals, because I know there's sharp ear listening for various comments. Also include facts during powwows, American Indian conferences, health directors meetings, to share the information with the communities. Our tribe, during the cultural awareness shell collection exhibit on the reservation, was there for 90 days, and we had 2 events for each month. First, there was the grand opening. We had a survivors panel, and we included men on the survivors panel. Even though the focus was women, we did not want to exclude anyone. And then there was an artist talk where I shared my experience, the video, and the experience of the case study individuals. And then there was a dinner. And we wanted to also, and there was a committee to decide these things. So we wanted to also have something for the youth to focus on. So the nutritionist from our health center came over to the Eagle's Nest, which is the gym on the reservation, and did a danger of energy drinks talk. And certainly the youth were there, but also elders, tribal police, medical staff from the health center on the reservation, and parents were also in attendance. So we had the Dress Red fashion show and dinner. This was a big hit, a lot of participation, and we turned the words Dress Red instead of Red Dress Fashion Show. Anyone who wore red could participate in the fashion show, which included men and boys and individuals of all ages. And as you can see pictured here, the little boy, and then a woman in her traditional dress, dancing down the runway in a traditional dance mode. And then the young girl, Maria, is a heart surgery survivor. She had open heart surgery at 3 months of age. So there was participation in that. And then there was community potluck, recognition of heart disease survivors. The women received red shawls, and the men received red bandolero bags that were made by the elders in the Andawad Center, which is the home for elders who need assistance. And I use the term nursing home, but I don't think they really care for that term. And Andawad translates to where we live. And then during the exhibit closing, there was a healthy food competition, and all members were included to come and bring their version of their healthy meal. And there was a competition, and it was really enjoyable. And we had judges. The judges are included an elder, someone from the health center, someone from tribal police, and a person from tribal council. And there were gifts won for those individuals who came into first, second, and third place. And then there was an exercise demonstration from toddlers rolling around and doing their tumbling, youth doing their rollerblading and hula hoop, and elders showing the type of exercises they could do. And again, we had another meal. So that was really an enjoyable event, and they have it every year. So just went really fast. More information: American Heart Association, Women's Heart Foundation, the Heart and Lung Association, the Fighting the Lady Killer website, sponsored by Barbara Streisand and Jordan Sparks, and federal government websites such as Indian Health Services. I'd like to say miigwech, thank you. Questions or comments? You have my email here, and these are little beaded strawberries that are about 1/3 the size of your small fingernail. Just wanted to see if I could do it, but and the basket itself is the size of a 50-cent piece. And strawberries are throughout this collection because strawberries, the word is translated to Odi, which is heart, for the shape of the strawberry and the color of the strawberry. Odiman is the full word, but Odi is used sometimes to indicate the heart. Thank you.
Thank you, Dr. Krause. It's beautiful work.
Thank you.
Important work. So we are at 5:30. For those who have questions, we can certainly, I think all of the presenters have given their email addresses and would welcome questions from you. And for those of you that need to leave, we understand. And we thank you for being with us for this afternoon's event. And we wish you lifelong well-being. For those of you that can stay, I'd like to extend this for another 10 minutes so that Nick has a chance to provide some information about some research on family caregivers, which I'm sure resonates with many of the people in our audience today. So if you need to leave, many thanks. Otherwise, please stay and hear Nick's presentation. Thank you.
All right. Hi, everyone. Thank you, Claire. So first I wanted to start by thanking all the other presenters and then also Dr. Anderson for everything he's done for osteopathic medical profession, and then in particular MSU Com. So, and then before we begin talking about the research that I've been working on with Jose and Dr. Luz, I just wanted to put it into context. So currently we're working on producing the survey, and then hopefully within the next few weeks, we'll be distributing it. Oops, excuse me. Okay. So historically, family members provide about 80% of care in home. And then there's been an ever growing shortage of family caregivers and then also paid caregivers. As a result of that, there's been a switch or a shift towards the younger generations providing care to older adults or other individuals that have a disability that requires support. And many of these students are simultaneously enrolled in college. So just a stat, 25% of family caregivers are college age. And then there's an estimate of like 11 to 17% of college students are simultaneously fulfilling the role of a family caregiver. Okay. And so just why do we care about how many college students are caregivers? It's because a lot of them face many different challenges in different parts of their life. So their academic performance may be affected, financial stability, ability to pay for school, and then mental health too. So those can be impacted. And then our study is specifically going to be looking at students at MSU and Eastern Michigan University. And we're going to look at the prevalence and then also the different aspects of their life that may be impacted by their dual role as a student and a caregiver. So specific aims that we're going for, with our research. So we first want to figure out what the prevalence of college student caregivers is at MSU and then EMU, and then identify the rewards and challenges of college student caregivers and what they're experiencing. And then lastly, we want to figure out a major emphasis of our research is trying to figure out what the resources they are utilizing are or haven't heard of, and then what other resources they might find helpful. So, okay. So our study is exploratory study. As I said, there's not really a great understanding about caregivers at MSU and EMU. And then the challenges that they're going to be facing. So we're trying to figure out more about that specific population of students. The way we're going to be doing this is we're going to send an email out to all the EMU and MSU, the whole entire student body. And it's going to have a definition of a caregiver, family caregiver. I'll go over that in the next slide so you can see what that is to us. And then it's going to have a link to a survey that's about 51 questions. Hopefully it'll take about 15 minutes for students to complete. And we developed this survey. So myself, Jose Reyes, he unfortunately couldn't present this with me today, but he's played a crucial role in the development. And then Dr. Luz. So we've been developing the survey based off of prior research at other universities and AARP research, for example. And to give an idea of what the research or the survey looks like, we have a demographic section, which is pretty generic, and then different section headings. So we would have describing the primary person being supported. So what age they are, who they are to the caregiver. Are they a parent, a grandparent? And then what type of disabilities do they have for why they need support by this caregiver? And then describing yourself as a caregiver. So the person will describe their responsibilities, what they do for the person they provide care for, and then discuss different aspects of their academic career as well. And then the impacts of their different aspects of their life. So how it's impacting their academics, their ability to adjust to college and their personal life, health, mental health in particular. Finances. And then, as I mentioned before, we're going to look into resource utilization. So what resources they're using and what they would like to see and what they would find beneficial. And then lastly, we had a free response, a few free response questions. And that's just to kind of go over anything we might have overlooked or something some ideas maybe that college student caregivers have that we couldn't think of. So, because we're not exactly in their shoes, so it'd be good to hear what they have to say for that. And as I said, here's the definition for a college student caregiver. This is going to be directly in the email that we have to send out to students, and they can read this. If they feel that they fit this definition, they can go on to complete the survey. So pretty much it's somebody who provides ongoing support and assistance to an older adult or young person living with a chronic condition, disability or life impairing health condition, while also enrolled as a student. And that can be full-time or part-time or vocational school. And then what they do, they could provide or help out with finances, personal care, running errands, assisting with appointments, preparing food. Pretty much what call are like ADLs and IADLs. And then how we're going to analyze this. So we're going to go through and tabulate different, we're going to try to create a profile pretty much for the typical or different college student caregiver profile. So based off of demographic data, and then the characteristics of the individual they're providing support for, and then responsibilities that the person is helping out with. So if they're helping out with, for example, going to the restroom or with transportation. So, and then the key predictor variables that we have here. or amount of time caregiving, level of support provided, level of support available, and then educational programs. And then primary outcome variables that we'll be looking at are difficulties. So this is pretty much how a college student caregiver is going to be impacted by their role. So difficulties in academics, health, personal life, and finances. And then we're going to use it's called a chi-square test to compare them. So to see how the predictor variables impact the primary outcome variables. So for example, is there a greater rate of depression in those providing more support? Are those associated at all? And then a few hypotheses that we have. We expect that the findings that we have at MSU and EMU are going to reflect or be similar to what they are at other universities. And then we expect that the dual role of caregiving and students, the dual role that they have, it's going to present challenges to their health and academic success. And then thirdly, we have MSU and EMU student caregivers have unmet challenges that they face. And then lastly, there are gaps in the services and resources for MSU and EMU students. So I'm going to go over some of the results from previous studies that we referenced when making the survey. And we expect, like the first hypothesis here, we expect a lot of the results to be similar, but we're trying to figure out for MSU and EMU particular. So first off, prevalence. So the prevalence is going to range from, or previous studies have shown that it ranges from 11 to 17%. And you can see from this AARP quote here from a 2020 study that that's about 5 million adults that are affected. So it's a pretty substantial population that we're looking at. And then the responsibilities of caregiving. So in general, the AARP study, for example, that we looked at, they found that most people being cared for or that support is being provided to are parents or grandparents. And the reason that support is required, generally it's a long-term physical condition, and then you can have superimposed short-term physical conditions, mental illness, emotional support is needed. And then you can see on the right graph here, this is from the AARP 2020 study, the hours of time provided, or the hours of care provided, it's pretty variable, but it's a lot of hours that these people are putting in, and you could see why the different parts of their life are going to be impacted. So impacts on college student caregivers. So 10% report that they that their academics are not affected. So that leaves 90% of people, of these students, that are affected by their dual role. 70% are concerned about their ability to continue their education. Many college student caregivers are overwhelmed. They feel disconnected from other students and alone as family caregivers. And many also face challenges in taking care of their own health. So, for example, college student caregivers report higher depression scores than non-caregivers. And then many are also impacted in regards to finances, their ability to pay for school. And then college student caregiver resources. So many feel that they can discuss their role with peers and academic advisors, instructors, and student counseling. And 66% believe the university should provide flexible policies, including assignment flexibilities and attendance flexibility. And in general, 51% believe that their university should give some type of support to them. For example, like many family caregivers, if they have children that they're taking care of, those individuals are supported a lot of times, but a lot of adult caregivers are left behind with those resources. As I mentioned before, previous studies have shown there's about 5 million college student caregivers. And we don't understand the exact prevalence of college student caregivers at MSU and EMU. So we hope to figure that out at this point. Universities have responsibility to help students to succeed in their education, career, and life. So that's where we're going to help try to create these resources, figure out where those gaps are at so we can fill them and help those students succeed. Some implications. We hope to increase the awareness of college, the high prevalence of college student caregivers, their needs, and then this has relevance to clinical care, development of needed resources, student health and success, and quality of care provided to loved ones. Improved awareness and access to current. So we hope to improve the awareness and access to current college student caregivers. So that would be creating programs so that college student caregivers are more aware of their what is currently provided for them, because a lot of times those resources are there, but they might not be they're just not prevalent, I guess. So, and then we hope to create new novel resources and policies to fill the gaps. So for example, at MSU, we have the Olin Health Center, and they could have a clinical intake form that just asks, are they a college student caregiver? So that healthcare provider at Olin is aware that they're a college student caregiver, and then they can be connected with the resources that they need. And then a lot of college student caregivers in previous studies have shown that they wanted training and time management and stress reduction from the university. And then they report that flexible assignment, testing, and attendance policies would help them in their success. And then also more online course formats, scholarships for students. So a lot of these bullet points here, the arrowheads, we'll have to figure out exactly what the college student caregivers at MSU and EMU would like, and hopefully we can fill those gaps. As I said, we're currently in the phase of finishing the development of the study or the survey, and then we're going to be sending that out soon. So we have to complete the data collection, analyze the results that we have from the survey, report the findings, and then hopefully to implement some of those resources, we can talk to MSU and EMU, and they can provide those resources and develop on new resources that college student caregivers would find helpful. And then lastly, examine the efficacy of the programs implemented by conducting follow-up studies. So here's our funding, Michigan Health Endowment Fund. And then I would like to thank AgeAlive, the other committee members, for allowing me to present. And then Dr. Luz, the host for tonight. She's been great in helping me develop this and guiding me along this. And then also I had mentioned Jose. He's a social work student at MSU. He's been done just as much as me, if not more, in developing this, and he couldn't help present this tonight, unfortunately. And then Shannon Harkins Paget for helping out coordinating a lot of this.
Great job, Nick. Thank you. All right. Great job. Thank you, everyone. I know caregiving is a big, important topic right now for a lot of people. So we hope to discover more about resources that will be helpful. And thank you to those of you who stayed on. We really appreciate you hanging in there. And a special shout out again to Amy and Devante and to all of our panelists. We are sorry for the time pressure. We'll provide more time next year for sure. But I am just thrilled with this whole event and everybody's participation. And so I am going to bring it to a close because I know we're past time. And so thank you, everyone. And again, please complete the evaluation. And on behalf of AgeAlive, we wish everyone lifelong well-being and hope you have a wonderful evening. Thank you.